Well, thank you very much for the opportunity to speak here and to share some thoughts. And in fact, many of the points I want to address have been raised by previous speakers. But I want to give it a slightly different angle. I want to put the discussion on health care ecosystems in the context of population-based integrated care, which is what we're doing. And just for transparency, OptiMedis is a private management company setting up integrated care networks in Germany and abroad. So in terms of the data ecosystem, what does it really mean for us? We talked a lot about data, and we've heard that data is often being kept in isolated databases, and they're not well connected in healthcare. And we have developed a model to bring these data sources together in order to inform ways to improve the triple aim, improving health outcomes, improving patient experience, and reducing per capita cost. What you can see here is basically our ecosystem where the different data entry points are being displayed. We've got insurance data, so from social healthcare insurance. We've got provider data from electronic medical records. We've got data from a management company which is locally registering people to participate in, say, self-management or prevention classes. And we've got primary data sources such as patient surveys, which are linked to this data. This is then being used in our analytical data warehouse to inform various standardized analytics tools that help us, together with the physicians, identify ways to target patients of high risk, high cost patients where early detection or early primary prevention is required, and we can also develop various predictive models. This approach has been recognized by various agencies and organizations, the EU, the World Innovation Summit for Health, and many others. But the question is really, why are we doing that? So why do we need to address the data ecosystem in our model? And what is really driving our work? And I think that's far more important a question than thinking about which data should be in which kind of database and what we can do with that. Our guiding principle is the triple aim, as I've just referred to: improving health of the population, enhancing patient care experience, and reducing per capita cost. And all that is related with the sustainability of the healthcare system as a whole and increasing health gain for individual patients. Now, however, this in many health systems is not really a guiding principle. Many health systems are designed on numbers of hospitals, numbers of professionals, numbers of patients, and we are planning numbers of hospitals and people needing to be educated to become a doctor. And hospitals, of course, are paid by episodes of care, and the whole system is not designed towards the triple aim. In our model, where the healthcare data system ecosystem is used as a lever to inform an outcome-based contract, we can actually go backwards. We can start with the outcome perspectives and ask ourselves, what outcomes do we want, do we have to achieve in terms of health outcomes, economical outcomes, and patient outcomes? And from there backwards, we can identify the care processes required to reach these outcomes. And then we can go backwards from the processes to ask, what kind of structures do we need to implement process to reach these outcomes? And that's actually, it seems logical, it seems simple, but it's just a reverse of the actual way health systems are organized. And I think that is quite critical. So barriers to developing such an outcome-based contract, a population-based contract, are the following, and these are just some of the main barriers. I mentioned the reimbursement systems. If a hospital is paid by episode of care, it has now incentive to improve health outcomes at the population level. That's a fact. Hospitals are also not rewarded for achieving certain clinical outcomes because that's not measured in a DRG, especially if you look at long-term outcomes and long-term, basically anything going beyond the discharge of the episode. Another barrier, we work with health insurance companies to use the data to run our models and to assess the potentials to improve outcomes. And insurance companies by nature have to be risk averse. They're not entrepreneurial organizations by their very default. There's also the whole notion about the GDPR compliance, and it's good that we have GDPR rules. It's problematic, however, that there are different interpretations of the rules. There are gray areas. And often we have, in the German context, seen situations where the federal data protection officer disagree with the regional ones who disagree with the local ones. That makes it incredibly difficult for an SME like ours to go through the process and to find agreements with these large organizations in the absence of very clear rules. And then it's a specialty in the German context. We have more than 100 insurance companies. Sometimes they work in competition, sometimes they are in cooperation. But if we truly want to use data ecosystems at the population level, we need to have a reasonable share of the population covered under a contract that is reflected in the data ecosystem. And they can only work if there's collaboration rather than a competition. The same goes for providers. Providers are also risk averse. And here we have the main barrier of data interoperability. I don't have to expand on that. I think there are progresses there, but it's still a long way. But another barrier is that some providers are very happy to engage in such a model, to share data, to compare, to learn from the data, while others, and that's not a secret either, particularly in the medical profession, there are providers that are not so eager to compare, not so eager to benchmark. So I think the difference between transparency on the one hand and opacity on the other is a real barrier that we have to address. Then to start any kind of new initiative, of course, you need an upfront investment. Sometimes it takes a while to reach a positive return on investment. I think that's common to any kind of entrepreneurial initiative, so I'm not going into more detail. But I think as the previous speaker, as Oscar also mentioned, there are technical barriers, but they're also cultural. And the technical barriers can often overcome. There are actually technological solutions to overcome those barriers. However, the cultural barriers are often much more difficult to overcome, much more resistant to change. And particularly in changing a health system that is focusing on value, on outcomes, rather than on counting people or counting cases and counting hospitals. So finally, what have we learned from our work? And I just want to highlight a few of those issues. We have made good progress in establishing regional organizations that can work with stakeholders in a much smaller context to find an agreement on what these outcomes should be, how the collaboration could look like, and what are the different wins for the different stakeholders involved. Of course, many of the issues that we're addressing today in this conference and that the other speakers addressed require national or even supranational norms, regulations, standards. But to move things forward at the local level, it's often the regional stakeholders that need to have a shared vision. And we have made that experience that having those regionally shared vision really helps us getting all the agreements in place to move forward. A lot of the technological work we're seeing in Germany in particular is driven by a very wide scope of future technological applications. And as someone with an affinity for technology, I get very excited about that. But we have made the experience that sometimes less is more. And with the wide possibilities offered by common data tools that we have now, I think we always need to keep in mind what is the use case. And I think I mentioned that earlier. What is the use case for local stakeholders, particularly the clinicians, if we want to get them on board to implement a new system? How can we make their life easier? How can we reduce bureaucracy and documentation rather than expand it? How can we make the interfaces more friendly? How can we make sure that clinicians also have an incentive actually to use the technology? And I think for me to conclude, the data ecosystem has a very clear and strong technological bone, and that was a backbone. That's the first image that I've shown with the data warehouse we set up, but it's the soft tissue around that. The soft tissue around the skeleton of the data ecosystem, which is reflected in the culture, in the relationships, in the shared visions, in the contracts and social contracts that we have with stakeholders on the ground that really help us move forward. How this could be addressed at national or supranational level, I don't know, up for discussion. But I think the angle to the discussion that I wanted to add is the focus on value and the focus on regional collaboration. And I hope that links to some of the topics we can discuss later. Thank you very much.